Welcome to Practical Perspectives as investigators discuss the current management of patients with paroxysmal nocturnal hemoglobinuria. This is medical oncologist Dr. Neil Love. For this program, I met with clinical investigators Dr. Jamile Shammo from the Northwestern University Feinberg School of Medicine in Chicago and Professor Alexander Röth from the West German Cancer Center and University Hospital Essen in Essen, Germany. Also included in this closed roundtable were case presenters Dr. Gloria Gerber from the Johns Hopkins University in Baltimore and Dr. Jamie Koprivnikar from the John Thur Cancer Center in Hackensack, New Jersey. To begin, Dr. Shammo and Röth provided an overview of this rare disease.
So PNH is a DAT negative hemolytic anemia, and there are a subset of patients that we need to identify and treat. But the identification of a PNH clone doesn't necessarily equate immediate therapy. So I think each patient needs to be evaluated in terms of the impact of a PNH/hemolysis on the clinical presentation, and then evaluated as such for potential therapeutic options.
Alexander, anything you want to add to that, particularly in terms of the diagnosis? Do we know how, rapidly or delayed the diagnosis generally is in these patients, how they present, and what are some cues for general medical oncologists to be thinking about this?
I think historically it was a big issue, and we saw delays about up to 8 years for patients with classical PNH symptoms or complications. And I think nowadays we are pretty much aware of PNH as a disease, how it can present. But those signs and symptoms may fluctuate, they may vary. And I think those name-given hemoglobinuria is only present in only 25 or 30% of the patients during the course of the disease. I think that's important to remember. And if you think about PNH, I think it's straightforward to actually diagnose it because you go for flow cytometry, and that can easily diagnose and find a PNH clone which is relevant in the cause of those complications. I think the signs symptoms vary. I think you have to think about all patients with a DAT negative hemolytic anemia, patients with unknown cytopenia, patients with thrombosis at various locations, at a young age, and so on. And I think that's probably triggers where we have to look for a PNH clone.
Jamie, any thoughts about, again, myths and misperceptions about PNH? I'm sure many of the patients that you see have seen general medical oncologists before they see you.
So I think that the really interesting aspect of PNH is that patients can really, even though it is a disorder of the hematopoietic stem cell, patients can really have manifestations that affect almost any organ system in the body. So interestingly, a PNH patient could be presenting to a specialist or subspecialist outside of the realm of hematology oncology. For example, we know that these patients may have shortness of breath or abdominal pain, so they may be seeing a pulmonologist or a gastroenterologist. And so we do have data that shows that these PNH patients, actually I think this is from a very nice paper that Dr. Shammo contributed to, will often see multiple physicians before they're ultimately reaching their diagnosis. And so it's interesting. We're taught in medical school when we hear hoofbeats, think horses, not zebras. But indeed, there are zebras out there, and in fact, the zebra is the mascot of the organization of rare diseases for patients. So even though PNH is rare, if we don't think about this diagnosis, we're certainly never going to see a case. So I just encourage awareness of the disease.
Did you say there's like an advocacy group, or what is this, a rare disease thing you just referred to?
Yeah, so there's definitely an organization. There are several organizations that really support patients with rare diseases, and certainly PNH is one of the causes that they champion. And I'm really excited. I think finally we've gotten to a point in medicine where rare disease in general is receiving the attention, or starting to receive the attention that it deserves.
So, yeah, one of the things I've noticed, for example, with desmoid tumors with the new agent nirogacestat is actually, it was an advocacy group that really pushed to get the trial, and they really made the trial happen. And I'm going to be curious to hear about these trials in PNH and how you get a trial done with such few patients. But first, let me ask Gloria for her take on this. Again, you seem to be the one who's closest to coming out of fellowship. What are some of the questions you think people have that we could maybe address for people not as familiar with this?
Sure. Well, I'm still waiting to make my first new PNH diagnosis. So it's certainly a rare disease, but as others hinted at, I think more commonly found than we would expect and can present with, a large variety of symptoms and manifestations. And some people call PNH the great masquerader. And we, like others have said, have diagnosed patients who've seen GI for, irritable bowel disease and are actually having are having kind of more a presentation of small bowel thrombosis or symptoms related to nitric oxide scavenging and more vasomotor type symptoms. So I think it's important to keep a broad differential. Also, to Dr. Shammo's point, I think the interpretation of a PNH clone can be quite challenging, and not everyone with the presence of a PNH clone merits treatment. And perhaps this is something we'll speak on later, but certainly thrombosis is an indication, symptomatic anemia, other symptoms of PNH. But we certainly find a lot of patients who have very small PNH clones, and that's actually indicative of an underlying bone marrow failure syndrome, like an acquired aplastic anemia. And those patients, from the perspective of their cytopenias, are unlikely to benefit from PNH-directed therapy with a complement inhibitor. So I think interpreting a PNH clone can certainly be a source of confusion and challenge, frankly.
So I want to begin to walk through some of the specifics here. And again, at this point, we're still sticking with the first-year fellow type approach. This is one of Jamile's great slides. And I thought maybe we could start out with this and ask Alexander to talk a little bit about your vision of the complement pathway and how it's altered in PNH.
So, in PNH, the problem of PNH is, on the one side, it's a form of cure from the aplastic anemia because those PNH cells are able to to hide themselves from the immune attack in aplastic anemia. But on the other side, and the drawback is that PNH red blood cells, they lack a GPI anchor, a general principle how to anchor proteins on the surface on cells. But those affected red blood cells, they lack complement regulating protein. And there are, which two are relevant, CD55 and CD59. Most importantly, CD59 for PNH, because they prevent the formation of the membrane attack of complex of the alternative pathway. The alternative pathway is something, it's a part of the complement system which is always active. It tries to activate itself continuously. And if you lack CD59, the membrane attack complex is formed. So you build a pore into the red blood cell, and just one pore is actually enough to cause influx of water into the red blood cell and the hemolysis of the affected red blood cells. So that's the general problem in PNH.
So Jamile, I want you to imagine you're walking down the hall with 4 first-year fellows, no slides, no nothing. You're just chatting in the middle of the room. You don't have this slide to explain to them. But can you kind of go back through some of the concepts that Alexander just brought up, some of the things that are in this slide, and sort of go through it, kind of basically?
So what I would say is that the complement is part of the innate immune system, which is responsible for eliminating non-self. And that's basically something that we've had for perhaps centuries, right? So that we can be protected from invading organisms, bacteria, etc. So the job of the complement is to identify what is not considered self and destroy it. And if you think about how it goes from C3 cleavage by C3 convertases, a bunch of enzymes that essentially are responsible for activating this molecule that ultimately propagates down to what we call terminal complement cascade, whereby C5 now is cleaved. So you have cells that are marked with C3b, which is the byproduct of C3 cleavage, that ultimately will be destroyed by the membrane attack complex. And this is very important because the complement in PNH is actually doing its job. It's eliminating abnormal cells, abnormal red cells in this case. But the problem is in the fact that you have red cells that do not express complement shielding proteins. And by that, I mean CD55 and CD59. So CD55, for example, kicks off C3b fragments on the red cells. So if you kick that off, then C5 won't be activated and MAC formation will be inhibited essentially because you have CD55. And when you have CD59, the assembly of membrane attack complex will not happen. But that's unfortunately not the case in patients who have PNH. So if they have their complement activated for various reasons, then you get propagation of formation of C3b, that ultimately all those cells are marked for hemolysis and what we know as intravascular hemolysis.
So I'm going to ask Jamie to elaborate on that and further explain your vision about what happens with these patients biologically and clinically.
Absolutely. And Jamile, I think you're absolutely right to point out that complement is doing exactly what it's intended to do in this disease. There's absolutely nothing amiss with the complement cascade, but rather it is the lack of these sort of what I like to think of as complement stop signs on the surface of the hematopoietic cells that really leave these cells open to the friendly fire, so to speak, of the complement system. And, this is not just a disease of the red blood cell. All of the hematopoietic stem cells are actually missing the expression of these, complement inhibitory proteins. And so in addition to the intravascular hemolysis that really characterizes PNH, we know that as the complement cascade completes, C5 is broken down into C5a and C5b. And, C5a in particular is a very potent inflammatory mediator. It generates an almost anaphylactic type of response and is going to activate platelets and white blood cells. And so this is largely what underlies the huge thrombotic risk that we see in untreated PNH patients. We know that thrombosis is the leading killer of PNH patients. And so, while certainly these patients suffer from anemia and the consequences of intravascular hemolysis, this is still very much, as Gloria had spoken to earlier, a prothrombotic disease. And that is oftentimes what is killing patients with PNH.
So, Gloria, do you want to add anything to this? And also, in terms of the location and clinical presentation of thrombosis, anything you want to say about that?
Maybe I can comment on the latter because I think my colleagues did a very nice job in explaining the complement activity. So the interesting PNH, so thrombosis in PNH is a common symptom. Prior to the advent of complement inhibitors for PNH, it was estimated to occur in up to about 40% of patients. And as Jamie said, was the leading cause of death. And with the advent of complement inhibition, that is no longer the case, which is a very important point. The interesting thing about thrombosis in PNH is, of course, you can get your run-of-the-mill thrombosis like pulmonary embolism or deep vein thrombosis. But what we see in a fair number of patients, over a third of thrombosis, is thrombosis at unusual sites. And this can be quite devastating thrombotic events. So things like cerebral venous sinus thrombosis, splanchnic vein thrombosis, so portal venous thrombosis, splenic thrombosis, leading to things like Budd-Chiari syndrome, et cetera. So, again, when you see unusual site thrombosis, that is often an indication in which I will look for the presence of a PNH clone.
Any explanation for why you see these unusual sites, Gloria?
Yeah, I think that's a great question. And I would open it to the group, but I'm not exactly sure. And it's something I've thought about. If some of it has to do with kind of various flow dynamics through the splanchnic circulation. But again, I think in a lot of complement-mediated thrombosis, we see unusual site thrombosis, but I don't think we have a great answer for that yet.
Alexander, any explanations you've heard or thought about why you see these unusual sites?
I think that there's no real explanation. I just remember one study where they looked for, in PNH patients, they looked for the platelets, and interestingly, there was an accumulation of PNH platelets in the abdominal area, probably explaining this trend to go to have thrombosis in the abdomen. But I think it's a complex situation. I think there are several mechanisms involved, complement activations. You also have like PNH platelets who can be activated, and so on. I think it's in part what we understood, but I think the most important thing it's clearly if you block complement, you're able to prevent those thromboembolic complications significantly.
So, Jamile, this is a slide I showed in your talk on PNH classification and clinical presentation. Can you comment on that?
Yes. So I think the spectrum of patients who have PNH truly is incredibly broad. And I think this was work from the PNH registry, whereby the clone size was correlated with the PNH clinical manifestations. So you can think of it as two sides of the spectrum and anything in between. On one side, you have bone marrow failure with a PNH clone, that these typically tend to be rather small. And the clinical picture is dominated by bone marrow failure. So not only do you have anemia, but you also have neutropenia and thrombocytopenia. And by the way, those patients were kind of excluded from participation in clinical trials looking at complement blockade. But on the other hand, on the very end of that spectrum, you see patients who have classical hemolytic PNH. So the clone size tend to be larger. And again, the clinical picture is dominated by paroxysm of hemolysis and chronic hemolysis in between. And of course, there is a large subset of patients that lie in between. That's why I think it's very important to kind of assess the clinical status of every patient who had a PNH clone relative to its size and the clinical context of concomitant cytopenias.
So, Jamie, anything you want to add to that? And also any questions that you'd like to see addressed maybe by Jamile or Alexander?
So what I would add to that spectrum of disease in PNH patients is that, as Alexander alluded to earlier, patients can actually move from one end of the spectrum to another. And I think that that's very important to know in monitoring our patients with aplastic anemia and other similar bone marrow failure disorders. So as Alexander mentioned, as aplastic anemia is treated with immunosuppressive therapy and the bone marrow reconstitutes, we can actually see rapid expansion of a PNH clone. And so where a patient may have started out on, one end of the spectrum with a very hypoplastic bone marrow, not really having enough cells to even lyse, as that bone marrow reconstitutes, the PNH clone can rapidly expand and a patient really may move closer to the classical PNH end of the spectrum. Now, it's interesting. We know that PNH is inherently associated with bone marrow failure disorders. And the question is, why is that? One hypothesis that I've heard is perhaps the target of that autoimmune attack on the bone marrow is, CD55 or CD59, or perhaps even the GPI anchor. And I think that's an absolutely fascinating hypothesis. And I would love to hear from Jamile and Alexander and Gloria if they have any other thoughts on this inherent association between PNH and bone marrow failure.
Gloria? Thoughts or comments?
Yeah, I think that the mechanism, as others have said, the mechanism is not completely elucidated, but is thought to be due to the PNH clone. So one important point is that the presence of a mutation in PIG-A, which is responsible for synthesis of the GPI anchor, which anchors multiple proteins to the cell surface. In the setting of PNH, we talk about CD55 and CD59, but there are other proteins, CD14, CD16, etc. That the mutation in the PIG-A gene confers the stem cell in a normal bone marrow environment, no conditional survival advantage. However, in the face of an autoimmune attack like an acquired aplastic anemia, then that PNH clone will expand because there is a conditional survival advantage. Which certainly lends credence to the hypothesis that that the GPI anchor itself may be a target in acquired aplastic anemia, but to my knowledge, the exact mechanism remains unclear. Another very interesting but rare, very rarely reported mechanism of expansion of a PNH clone, and we have 2 patients, I believe, who fall into this category, is that the hematopoietic stem cell that acquires a mutation in the PIGA gene also acquires a second mutation that leads to a survival advantage. So we have patients who have mutations, let's say in JAK2 or CALR, that leads to a myeloproliferative phenotype, and then therefore the PNH clone will expand in that setting as well, although that's very uncommon.
Alexander, anything you want to add to that?
I just want to make some comments or observations we had recently, and I just remember a patient who was completely aplastic and had a PNH clone of size around 100%. So of course, if you have 100% of 0, it's still 0, but I think that's a high PNH clone size not automatically equals a clinical PNH. I think that's something which is important. And the other thing we just recently got aware of, and I'm following actually 1 or 2 patients with ahemolytic PNH. I think that's a special situation. So they have only few PNH red blood cells, but they have a high fraction of PNH granulocytes. So almost around, in our patients, around 100%. And he has still had two infarctions, so 2 thromboembolic events, despite having no PNH red blood cells. So this further shows that it's not only the intravascular hemolysis, but also the PNH granulocytes could be relevant.
All right. Well, let's again. I'm going to put you back walking down the halls with the fellows there, Jamile, and maybe just get into the basics of what the tools are we have to manage this disease, and particularly pathophysiologically, how they work.
Yes. So we have several PNH therapies that all of which are essentially focused on blocking key complement protein, if you will. So the very first set of therapeutics were focused on blocking the cleavage of C5 in the form of eculizumab or ravulizumab, both of which are monoclonal antibodies that recognize a certain epitope in C5, block it, and prevent its cleavage, so that now you've abrogated the formation of membrane attack complex, and therefore those cells, which are seemingly abnormal, will not be lysed accordingly. So this is the very first wave. Not too long ago, crovalimab, which is yet another C5 blocker. I know we have an expert in crovalimab. Dr. Röth has conducted the Commodore, vast experience with the Commodore trials, and I can't wait to see what he has to say. But this recognizes a different epitope on C5, and hence could work in a subset of patients that have C5 polymorphism. And I'll let Alexander comment on this. But as a consequence to C5 blockade, and as we've already talked about how all those abnormal cells are marked by C3b fragments, because C3 is still activated and you don't have CD55 to destabilize the C3 convertases, a lot of anemia sort of manifested in the setting of C5 blockade. And that was sort of promulgated the desire to develop other therapeutics that are higher up in the complement cascade. So this led to the development of pegcetacoplan, which is a C3 blocker, essentially a very similar mechanism for what I described with C5. And here, the idea is that if you block C3 activation, then you will actually abrogate the development of extravascular hemolysis, that is, because there will be no more formation of C3b on those disease red cells. But it's sort of a paradigm shift such that we've moved from complete control of IVH to proximal complement inhibition. So this third wave of compounds looked at proteins in the alternative pathways. So now you have iptacopan, which is a factor D inhibitor, as well as danicopan, although iptacopan is a single agent that you could use in an oral route of administration, whereas danicopan is an add-on therapy. And this drug inhibits factor D. And I can tell you that in the future, there will be, or there are actually endeavors to develop complement inhibitors even upstream from this particular pathway, essentially molecules that regulate or control the cleavage of factor D or B.
Alexandra, do you want to, we'll get more into the trials, but just in terms of mechanism of action, you want to elaborate a little bit more about crovalimab?
Yeah, so crovalimab is a novel anti-C5 antibody, which has which is highly engineered, so it's optimized an antibody which has several features. So it's only the uptake is only given when the antibody is fully loaded with C5. So and on the other side, he has an affinity to the neonatal Fc receptor, which is an endogenous mechanism on how to recycle antibodies. And the uptake, it binds to the neonatal Fc receptor in the cells, and it loses the C5. The C5 gets destroyed, and the antibodies are released again, and enabling this kind of recycling. And with this and with this high concentration, it's a high concentrated formula which can be given sub-Q. That's probably the necessary to give an antibody in a sufficient, in easy way sub-Q. So you only have to use 2 milliliters times 2 every 4 weeks to do this treatment on a chronic basis. So that's really something for the patients. It can be done at home, and it greatly eases the use of the anti-C5 therapy.
So I want to get your thoughts on a few clinical scenarios in a second, but first I want to go back to Gloria. Any more thoughts about the mechanisms of these agents? Also, is there any downside to blocking the complement system? Any alterations in normal function?
So the main concern with complement blockade is the increased risk of an infection and a most concerning and increased risk for meningococcal infection, as you highlight here on this slide. Now, all patients who receive complement inhibitors are required to receive meningococcal vaccination and remain up to date on that. And depending on the specific complement inhibitor, there are various other vaccine requirements like the pneumococcal vaccine, et cetera, that is specific to the various complement inhibitors and the approval requirements. The risk of meningococcal infection is still quite low. I've seen it estimated at about 0.25 events per 100 patient years, but that's still an 1,000-fold increased risk from a patient not on complement inhibition. And clearly we all know that meningococcal infection can be quite devastating. I guess in terms of questions for the group, which I think raise a couple of interesting points as we're talking about vaccination and meningococcal infection, I think there are two perhaps differences in management practice that I think we could discuss. The first is timing of meningococcal or vaccination. Our general practice here, let me go back. Our general practice here is to give the complement inhibitor, provide antibiotic prophylaxis for, several weeks duration, and then, vaccinate shortly after the complement inhibitor is given. That is because we know, and there's also been reports in the literature from the Leeds UK group, that vaccination can be what's termed a complement amplifying condition and can lead, in some rare cases, there's been a reported association with thrombosis or increased hemolysis. I know, however, that the FDA package insert in many practices is to vaccinate 2 weeks in advance of providing the complement inhibitor. So I think that's one thing that perhaps I'd like to ask the group their practices around.
That's a fabulous question. I love questions that are so practical like that. Jamie.
I think that's a very practical and conservative approach. It is much the same approach that I take, especially when we think about some of these proximal inhibitors where it's not just one vaccination, but actually multiple vaccinations. For example, against, not only meningococcal infection, but also strep. And then, although Haemophilus is no longer being included in the PI for these agents, some of us may still choose to vaccinate against Haemophilus. So that tends to be my practice as well. And again, I think it has sort of, very little downside as long as we appropriately counsel the patients. I've certainly had a patient, even on active PNH therapy, who related an incidence of receiving his COVID vaccination and noticing tea-colored urine for several days afterwards. So just in my clinical practice, I've seen the fact that vaccination can certainly be a complement amplifying event that could tip a patient over into having some PNH attributable symptoms. So I think that's a great point that you brought up, Gloria.
Alexander, any comments?
I think we noticed this problem early on, and it was hard to actually to convince people for clinical trials to really follow along this recommendation. But it's clearly the same practice here. So we started the treatment, and depending on the drug, we do simultaneous vaccination. And as already mentioned, I mean, for those proximal complement inhibitors, it's really a strong vaccination. So you have the tetravalent conjugate vaccine for meningococcal infection. You have the B vaccine, which is really immunogenic. Then you have the pneumococcal vaccination and the Haemophilus vaccination. So four vaccinations. Actually, for iptacopan, for example, after 2 hours of intake of the drug, you have a sufficient level of complement inhibition, and then you can do your vaccination. But and then we, as already mentioned, we also do prophylaxis for 2 weeks with penicillin. Probably also, and this is also something we have to keep in mind, also probably eradicating patients who have meningococci on their flora as in their nose or something. So this could also be the case. And that's with this approach, we have never seen any real severe problems or issues. But I think it's really not acceptable to vaccinate 2 weeks in advance before the start of the treatment.
So Jamile, in your talk, you mentioned a number of dilemmas in PNH, and one is the issue of initiation of treatment. Can you comment on that?
We talked about identifying patients, and I think practitioners have done a fabulous job in identifying and testing for PNH. That task is maybe not yet perfected, but we are identifying patients a whole lot sooner than we have in the past. But I think the second dilemma now is, when do you actually treat somebody? And especially if you have someone who may have relatively smallish clone size, maybe 20, 30%, you're not totally convinced that they are hemolyzing. But there are patients that must be treated and they are not yet treated. And that actually causes a lot of stress for me, because I realize that the consequences of having untreated disease are relatively enormous, right? So we don't have, at least in the United States, perhaps in Europe, Alexander could comment on that, but there are no very straightforward treatment guidelines. When do you actually think to start therapy on someone? On the other hand, when should you not start therapy on someone? Someone has a PNH clone size of 1%. I would not be treating this patient with complement blockers. So I think we need a little bit more clarity on what to do with this patient population, especially if they have a reasonable size clone and maybe, let's say, some feature of hemolysis, but they're not fitting the bill for what used to be described as paroxysmal nocturnal hemoglobinuria. So I think we need a little bit more definition of what would be an appropriate timing for treatment of those patients.
So, Jamie, any comments? And could you describe a clinical situation where you would hold off on treatment?
Sure. So I think first, my sort of rationale for treatment is based on data that we see coming out of a South Korean registry of PNH patients, where we see that the best discriminating value for LDH was not a particularly high LDH, actually. There has been association with LDH as low as 1.5 times the upper limit of normal as being a risk factor for thrombosis in patients with PNH. Now, when we take that elevated LDH and we combine it with a PNH attributable symptom, such as chest pain, for example, we know that that's really kind of synergistic in terms of increasing the risk of thrombosis in a patient with PNH. The other thing that I would add is a lot of, in terms of clone size, while, it's unlikely that a patient with a clone size of 10% or less is going to have clinically significant PNH that requires treatment, the clone size does not necessarily correlate well with disease activity, and we do have some evidence to support that as well. So I think rather than looking at a specific percentage of PNH clone, we really do need to look at factors such as LDH and PNH attributable symptoms. Now, certainly in my patients with aplastic anemia, there are lots of these patients who have very tiny PNH clones. Our sensitivity in being able to detect a PNH clone using peripheral blood flow cytometry is really quite good. So, certainly we're following lots of patients with clone sizes less than 1% who are not going to have clinically significant PNH or require treatment at that particular clone size.
Just as I'm listening to this conversation, Gloria, I'm kind of like, and there are many other diseases where I think about this. You kind of wonder whether or not a general medical oncologist, community-based practice, rural area, for example, should be managing these patients without some kind of input from a tertiary center. We were all excited when after the pandemic, we saw so much telemedicine going on. We thought that might be helpful with these rare conditions. But do you think it's okay for a general medical oncologist to try to manage one of these patients without some kind of input from a tertiary center, Gloria?
I think to your point, both the diagnosis and management of PNH, while we have more tools, is only becoming more complex. And I do think it's very reasonable for patients with PNH to have at least a one-time or every year, every couple year evaluation at a tertiary center. And by tertiary center, I mean, by a physician or a group that sees, a large number of PNH patients. But I do think inherently managing one or two patients in your practice with PNH, could pose challenges, especially as we think of the new complement inhibitors. Of course, it's wonderful to have more treatment options for patients, but I think it brings certain complexities. For example, we don't have kind of a strict definition of what qualifies as extravascular hemolysis. And, as we've all discussed before, some of these patients, can have worsening anemia and symptomatic anemia, and that might be related to extravascular hemolysis, but it might be related to a whole slew of other factors like worsening bone marrow failure. And I think the last thing we would want is for patients with, let's say, bone marrow failure to continue to cycle through different complement inhibitors without an improvement. So I think a lot depends on the, comfort of the physician, but I also think it's very reasonable to have patients evaluated in tertiary centers. And I would ask Dr. Röth, but what it's like in Europe, but I know at least from speaking to colleagues in the UK, they have a group of physicians that actually travels around and sees these patients, whereas healthcare in the United States is so different. Part is dictated by where you live. Part might be dictated by insurance requirements. So I think there are so many factors that question brings up.
So yeah, Alexander, your country's to me the leading country in the world from my point of view in terms of getting trials done. It's amazing how effective you all are. How do you manage? How do you care for people with PNH?
Yeah, I can only tell for Germany, but we have developed some centers with excellence and who sees a lot of patients with this rare disease. And for speaking for Essen, I think we are in the middle of Germany, so it's easy actually to reach. And I see patients. Of course, I see patients on a regular basis on treatment, but even patients from far away, like 300 kilometers, is probably nothing for the US, but I think it's a lot for Germany or Europe. So, and I would clearly recommend, and as already mentioned, of course, it depends on the physician. If you're comfortable to follow patients with such a rare disease, I think there are a basis of an analysis you should do on a regular basis. I mean, you can manage, you have a clue what's going on in the respect of the intravascular hemolysis, looking at the LDH level. You can estimate the extravascular hemolysis, looking at the reticulocytes and bilirubin. And I think there, and of course, you have the hemoglobin, which is a general marker of the degree of hemolysis. And then there are a lot of other factors, but I think this is, so the basis diagnostics you really should do on a regular basis on your patients with PNH, being on treatment or being not on treatment. So I think that's something which is relevant. And of course, and already mentioned now, we have those highly effective complement inhibitors where they almost normalize with the hemoglobin. Of course, you have to look at the PNH clone over time, because somebody might lose their PNH clone and then the complement inhibition is not necessary anymore. I think that's all those things which have to be kept in mind. And as the group already mentioned, those patients who initially got into the clinical trial, Triumph and Shepherd, those were those classical patients, high LDH levels, over 3,000, regular need for blood transfusions, 2 or 3 units every 3 to 4 weeks. And we don't see those patients anymore. So we have, as already mentioned, we have patients early diagnosed, PNH clone sizes around 20, 30%. And sometimes it's hard really for me to decide what to do next for the patients. You have to follow them on a weekly or a monthly basis, and to see where you're going. Is the PNH clone increasing? Do the patient have symptoms of PNH? I just saw a young woman who had clearly elevated LDH levels, and she was reporting abdominal pain on a regular basis, and she had an elevated D-dimer as a marker of coagulation activation, and we decided to start her on a C5 inhibitor because she wanted to get pregnant, and the abdominal pain was gone. She normalized her LDH level, but she's still slightly anemic. So I think these are the decisions which could be really not that easy to make.
May I interject, Neil?
Sure.
So, when I was trying to say that we need the timing for initiation of therapy, I meant that patients, to Alexander's point, present with symptoms of hemolysis, hemolytic anemia, and a lot of symptoms that come with active disease. And for whatever reason, they're not being treated. Not too long ago, I saw this young man who reported ongoing abdominal pain and hemoglobinuria and chest pain and trouble swallowing and erectile dysfunction and all the symptoms that you would imagine. In fact, he even had a clot, right? But it was deemed as provoked because it happened after an orthopedic surgery. So with all of this, he was not yet started on therapy. So I think I cannot overemphasize familiarity. All of us here know exactly what to look for. But for someone who takes care of a patient or two, do they know that abdominal pain may be associated with, hemolytic episodes, or let's even say subclinical PNH? I don't know. And I think we need to make a concerted effort to make it a little bit clearer and easier to say, okay, this person really should be starting therapy.
So a lot of these issues we're going to get into with the cases, but a couple more issues I'd like to hear you kind of discuss before we get to that. So Jamie, one of the other dilemmas that Jamile brought out in her talk was the issue of extravascular hemolysis that you referred to, residual anemia. Can you talk a little bit about what that is and what some of the solutions are we have for that?
Sure. And, this is actually kind of a unique phenomenon, this concept of this clinically significant extravascular hemolysis that we see when we're blocking C5. And so as we block C5, we still have unopposed the more proximal portion of complement, which can, in certain patients, so we know that there is C3b coding of the red blood cell in basically all patients treated with C5, if we look closely enough. Now, not all patients will experience a clinically significant extravascular hemolysis because of that, right? It's a subset of patients. We think maybe it's somewhere around 30% of patients, which when treated with C5 blockade will develop this extravascular hemolysis that occurs in the liver and spleen. And so, again, for many, many years, we had only C5 therapy, which, there's some data that shows that this actually brings the survival of a patient with PNH to be comparable to that of age and gender matched controls. However, there was concern that a subgroup of these patients continued to have ongoing anemia and fatigue and may even require transfusions. So the answer to that, and again, this could be multifactorial because this is a disease that's inherently associated with bone marrow failure, but certainly this extravascular hemolysis was thought to underlie some of these symptoms and transfusion burdens. And so as we develop the ability to inhibit complement more proximally, whether that's with a C3 inhibitor or a factor B or a factor D inhibitor, we are able to address or effectively shut down that hemolysis that may occur more proximally in the complement system in the extravascular spaces. Now, it's important, I think, to note that this extravascular hemolysis, or EVH, has not necessarily been shown to be as directly associated with thrombosis as the intravascular hemolysis that's C5 mediated, but nonetheless, it may result in transfusion requirements and significant symptoms and fatigue on the part of these PNH patients. So I think it's great to have these newer options for patients who may have clinically significant EVH.
So before we get into specific therapeutics and your thoughts about that, one other topic, another dilemma brought up by Jamile, which I'd like her to comment on, which is the risk of evolution to aplastic anemia or myeloid malignancy. Can you comment on that, Jamile?
So that is basically a problem that we would not be able to address. Of course, you monitor the patients moving forward, you monitor the blood counts, you ascertain that their hemolysis is under control, but the natural history of patients who have a form of bone marrow failure is to some extent unpredictable. I have seen patients who had hemolytic PNH that end up evolving to aplastic anemia and had to go for transplantation. And I have seen patients who developed MDS and then ultimately evolving to AML. Now, fortunately, the percentage of patients who evolve as such is rather small, particularly when it comes to myeloid malignancies. And, nowadays we have this advent of next generation sequencing, and we have the ability to evaluate for the presence of certain acquired mutation that may have a poor outcome. But what I meant to say when I put this bullet out there is to say that we have much less control of those types of evolutions or morphosis of this disorder than we do when it comes to controlling hemolysis, because we have developed such amazing tools to do this. But those two problems, I think, are things that we have to monitor for. Not that I have a great solution for, except to consider transplantation.
So, Alexander, the last two comments there were a lot of content there. Any thoughts?
I think it's important to remember that if we consider other clonal disease, and PNH is one of the clonal disease, that in PNH we try to protect the clone from destruction with our complement inhibitor, and usually we try to get rid of the PNH of a clone, not the PNH clone, but in other disease we try to get rid of clonal disease, and I think that's probably an issue. And on the long run, we have to ultimately cure the disease, which should be the goal on the long run. And in the future, we somehow have to get rid of the PNH clone completely. And that's what we see in some patients who reduce their PNH clone to a significant proportion, or always lose their PNH clone completely in respect of or in sense of a complete remission. I think that's something which have to be kept in mind, and it's important to follow patients closely in this respect.
So let's talk about anti-CD5 agents. One can start out with eculizumab. Not without the details in ravulizumab, and come back to you again, Jamile, to just provide sort of a historical and clinical overview from your point of view of these two agents.
Yeah, so I think a major advance in the treatment of patients who had PNH was the development of C5 blockers in the form of eculizumab initially, and then later on ravulizumab. So ECU is essentially a C5. It's a monoclonal antibody with specificity for the C5 molecule. And it was developed, it's actually very interesting, the paper on Röth, how this antibody was altered such that it maintained its specificity for blocking C5, and at the same time, much less likelihood of developing anti-monoclonal antibodies by the patients. So it is fascinating. And not only that, we've learned that in patients who have transfusion-dependent and hemolytic PNH, you have 50% reduction or ability to achieve transfusion avoidance. So then that was the initial drug that was approved, and it took about a decade to come up with ravulizumab. And again, this was sort of a genetic engineering of that particular monoclonal antibody whereby 4 different amino acids were altered. And now you have, and I'm really curious to see what Alexander thinks about the change or the similarities between ravulizumab and crovalimab in that regard, because this drug also has the capacity to dissociate from C5 in an acidic environment within the cell or the lysozyme, and then it binds to FcRn as you would typically recycle antibodies to capture more C5 molecules, and hence a much longer half-life. And so therefore, because it has 4 times the half-life of eculizumab, you can give it less frequently, so IV every 8 weeks, and that actually impacted patients' quality of life rather positively because they were kind of tethered to the infusion center, having to come back every 2 weeks. This novel agent, ravulizumab, was compared to a standard of care at that time, eculizumab, in 2 trials, in treatment naive, known as the 301 trial, and in treatment experienced eculizumab patients, showing that across the board, whichever primary endpoint you looked at, whether it's transfusion avoidance, LDH normalization in the treatment naive, or change in LDH in the treatment experience, that there was non-inferiority component telling you that the drug is just as effective as eculizumab. And that's how the drug got approved in 2018. So there's no doubt that there was a tremendous shift and improvement in the quality of life of those patients, in their survival when compared to the general population. And I think we have seen this. People like us who have seen pre-C5 blockers or pre-PNH-directed therapy can totally see the difference between the olden patient population and what we have to deal with right now.
So before I ask Alexander to talk a little bit about crovalimab, any situations right now where when do you use eculizumab right now, Jamile, if at all?
No, I use eculizumab. I mean, it's the only drug that you can actually treat when someone is pregnant, because there's some data suggesting relative safety of this compound in people who have PNH and are pregnant. So that's one possibility. And in the United States, if you have someone who may be treated on ravulizumab, they get hospitalized and let's say they have breakthrough hemolysis or they need to be treated, the only drug that's available on formulary would be eculizumab. So that would be the other possible. Someone with breakthrough hemolysis on a proximal complement inhibitor will likely also receive eculizumab in the hospital.
So after Alexander talks a little bit about crovalimab, I'm going to come back to Gloria, and maybe you can bring some comments or thoughts or questions up about the issue of pregnancy in patients with PNH. But Alexander, can you talk a little bit about crovalimab and how it differs from the previous 2 agents we just discussed, and right now, putting aside sort of regulatory issues, where you think ideally it should be used?
So crovalimab is pretty similar to ravulizumab, but has the advantage that it can be used in low volume sub-Q application. I think that's the difference. And I liked the evolution from the C5 inhibitors, like from eculizumab, because here I think the dosing was not done right because it was early times and we were not aware of the issue. And 20% of the patients had the doses were too low to completely cover situations where complement was amplified or or other situations. And this evolution was done in ravulizumab, where the dosing was done correctly to really protect patients. And probably also the recycling mechanism protects patients from complement amplifying situations. And we were really lucky to have this evolution of the C5 inhibitors during the pandemic. But just imagine what would happen for patients on eculizumab during infections and so on. They would have broken through on a regular basis. And I think this was really great, and it was really a relief for most of us and the patients during the time. As mentioned, crovalimab is a recycling antibody, low volume sub-Q application, and was tested in several trials. We were participating in the early phase 2 trial, the Composer trial, and where we identified the right dosing and the right mechanism of application and frequency. And this was then transferred to the Commodore trial for naive patients in Commodore 2 and experienced patients on C5 inhibitors in the Commodore 1 trial. So, and with here, and some data is shown here, patients were able to, and it was confirmed that this treatment was non-inferior to standard of treatment with eculizumab. So, and similar to ravulizumab, and this led to the approval of crovalimab as a treatment for patients with PNH naive or experience with C5 inhibitors.
So what is your preferred C5 inhibitor, Alexander?
I think the patient like really crovalimab treatment, the ones we put on, and they showed really nice results, almost normalizing of the hemoglobin, less problems with breakthrough hemolysis, and independent treatment strategy to use this at home, which is possible in Europe. And I think it's ultimately, if we talk about all the complement inhibitors, now it's more or less an issue also of the patient when what to use and what the preferences are. If you have to take an oral drug, I think you have to make sure that you're able to do that on a regular basis. With the sub-Q applications every 4 weeks, you don't have to do it on a daily basis. And probably, but of course, you have to do it on every 4 weeks, and with some days in between as a probable puffer. So I think that's in issues and of patients. Some patients want to be more independent. They don't have to come into the center to get their treatment, as in compared to an IV treatment. So these are all issues we have to discuss nowadays with the patients and to find the right treatment.
I guess there's not a simple answer to that question.
Yeah, it's not. You cannot dictate the kind of treatment strategy to your patient. And a lot of patients are already aware of options, and they clearly tell you what they want to have for the future of their treatment.
Interesting.
I would absolutely agree with Alexander that this, treatment strategy has to be highly individualized for a given patient. Paradoxically, in the US, the approval of crovalimab is such that it actually has to be administered sort of within the physician's office, whereas interestingly, for the intravenous C5 inhibitors, eculizumab and ravulizumab, I actually have some patients who are mandated by their insurance to receive those in the home. So it is kind of an interesting treatment paradigm here in the US that is distinct from what we're seeing in Europe, and I just wanted to kind of bring that out as part of our discussion.
No, that's really important that there are differences, but our practice during the clinical trial was to teach the patients early, and they were doing it on a regular basis, and they really liked what their sub-Q application. So this was easy, and they gave the patients the necessary independence.
Yeah, it's really interesting. Gloria, we're about to present a 32-year-old woman. I was going to ask you about the issue of pregnancy before we get into this case and PNH. Any thoughts or questions?
Sure. I mean, I think pregnancy is an interesting topic for all of us to comment on and discuss, because it's certainly a challenging time in the management of PNH. And I will say, for a patient who has PNH who may not otherwise be on a complement inhibitor that you're watching, who has maybe very mild hemolytic anemia, et cetera, I do believe pregnancy is a time in which I would very strongly consider or recommend starting complement inhibition. We know pregnancy is one of these complement amplifying conditions, which include surgery, vaccination, infection, things we've all touched on. And even in, healthy kind of physiologic pregnancy, complement levels rise, near delivery. And so we often see issues in pregnant patients with PNH kind of towards the end of the second trimester. And that's often with things like breakthrough intravascular hemolysis, requiring transfusions, worsening symptomatic anemia. Historically, we have treated with either increasing doses of eculizumab or more frequent doses of eculizumab. Prior to eculizumab, there was about a 25% maternal mortality, again related back to thromboembolism during pregnancy. There is some data with eculizumab in pregnancy that suggests that eculizumab is not present in the breast milk, and if it does cross the placenta, it is not in levels high enough to affect complement in the neonate or the fetus. So there is, good safety data there. Fetal outcomes, however, with eculizumab have not been changed, and there is an increased rate of adverse fetal outcomes like preterm birth, small for gestational age. I will say to Jamile's point, we have here in several patients, especially patients who've had, difficult to control anemia on eculizumab or were previously on ravulizumab through their pregnancy and doing well, treated a couple patients with ravulizumab during their pregnancy. I think this is an ongoing area of investigation that, clinicians and researchers are continuing to look into and try to amass data. In our pregnancies, these patients have had less breakthrough intravascular hemolysis because we know, again, this is more weight-based dosing. The half-life of ravulizumab is lower, so there's kind of less breakthrough hemolysis as compared to eculizumab. So I would be interested to hear others' practices and thoughts. I think this is still a controversial area.
So, Jamie, I'd be curious how you approach this, and particularly how you sit down with a woman who wants to become pregnant and, provide informed information.
Absolutely. I mean, I think this is really very relevant because we know that the median age of diagnosis of a PNH patient is, really in the 30s or perhaps the 40s. So this is certainly affecting women of childbearing potential. And so, with these newer medications, the more proximal inhibitors, while they may be really attractive in terms of, sort of lifestyle considerations and that they may be oral, I don't think we have really any data to support their safety in pregnancy and perhaps even reason to believe that they may have some teratogenic effects in certain cases. So I think that it's really important to carefully kind of plan reproductive considerations for women with PNH, and certainly with any attempt at trying to conceive, I would plan to really switch these individuals certainly to a C5 inhibitor. And again, while there may be some forthcoming case reports of ravulizumab treated patients in pregnancy, certainly the agent with which we have the largest volume and body of experience is eculizumab. And that remains really our agent of choice in pregnancy. But I think that Gloria, pregnancy is a hypercoagulable state to begin with. So I think that, Gloria, you bring out excellent points, and that, the hypercoagulability of pregnancy can certainly be magnified, obviously, in the setting of a patient with a PNH clone. And these are really complex patients who may require dose adjustments of their eculizumab in later pregnancy. And this is certainly somewhere where if I were, an individual, a physician who had one of these patients, I would definitely be talking with someone at a tertiary center where I'm managing a pregnant PNH patient.
To Jamie's point as well, we also usually do start prophylactic doses of anticoagulation in these patients, usually after the first trimester.
So let's move from the, hypothetical to the real. And Gloria has a 32-year-old woman, speaking of young women, she put it together as a really nice teaching case for us to respond to. So, Gloria, tell us about this patient.
Yeah, so this is a 32-year-old woman who's referred to your office for a new diagnosis of PNH. She initially developed symptoms starting with fatigue about a year ago. At the time, she had a CBC that was notable for macrocytic anemia, mild thrombocytopenia, and leukopenia with very mild neutropenia, but no infectious symptoms. Over the year, she was followed locally prior to this diagnosis, and over that year, she did require 2 units of packed red blood cell transfusions for a hemoglobin of 5 after a viral infection. She comes in today reporting ongoing fatigue, and she feels like when she comes home from work, she just has to go straight to bed. And here are her lab results at the time of her visit with you. Her hemoglobin is 7.6. She has a mild reduction in her white blood cell count. Her platelet count is 120,000. She is reticking briskly. Her LDH is 1900. She has a very mild elevation in her AST, 87. Her bilirubin also is very mildly elevated at 1.3 with a normal creatinine. We can see she's iron deficient, and her urine is positive for trace blood, but no red cells on morphologic examination. Prior to her seeing you, she had a bone marrow biopsy that was mildly to moderately hypocellular for her age, 40 to 50%. There is trilineage hematopoiesis with an erythroid predominance. And the diagnosis was actually made because of flow cytometry on the bone marrow, where it showed that her monocytes lacked CD14 and CD16, and her granulocytes lacked CD16. Again, so the pathologist brought up, checking for PNH. So there was a PNH flow. On this flow, she had a very large white blood cell clone, 97% PNH granulocytes, 95% PNH monocytes, and her red cell PNH clone was 51%. And I'll highlight, when we talk about red cell PNH clones, we talk about type 1, type 2, and type 3. Type 1 red cells are normal, so completely normal GPI expression. Type 2 red cells have a partial reduction or partial loss of GPI anchor proteins, and so there's some protection from complement, and type 3 is a complete deficiency of GPI anchored proteins on the red blood cells. So that's important when you're reading a flow.
So let me come back to you, Jamile, and maybe you can just sort of, before she actually has a bunch of questions around the case, before we even get to that, can you kind of translate what you've heard so far?
Yes. So thank you, Gloria, for this case. Essentially, we have a young woman who has clear evidence of hemolysis with mild cytopenias and bona fide evidence of a very large PNH clone combined with some iron deficiency, likely related to hemoglobinuria and active disease. I was worried that Gloria was going to tell me, and she received IV iron for the tune of anemia. I'm glad I didn't hear that, because that's actually a frequent occurrence when people have anemia and iron deficiency. And that usually exacerbates, at least in my practice, I've seen exacerbation of hemolytic events because of taking care of this iron deficiency in an untreated patient. So it's straightforward. This patient requires treatment, initiation of PNH-directed therapy, and I will leave it at that.
Before leaving it at that, actually, Gloria has a bunch of more specific things about this case. But before we get to that, I'm just kind of curious, based on what you've heard, Jamile, what would be your likely very specific recommendation?
You mean like what type of treatment would I
drug?
Recommend?
Yeah, which specific agent?
Okay, so that's actually an important question. It's obvious that we have a lot of treatments that are available for the management of those patients. But to me, I think the long-term data on survival, on reduction of thrombosis, and on efficacy and mechanism of action, if you will, would probably prompt me to utilize a C5 blockade in this patient population. Do I not consider other treatment options in this case? I would. My only issue with that is that the proximal complement inhibitors have reported data on treatment-naive patients, but in both instances, except maybe with the Commodore trials, but that would also be a C5 inhibitor, these trials were not comparing patients who were treatment-naive head-to-head with C5 blockers. And so while I know that they are effective, I don't have a frame of reference as to the superiority or even non-inferiority, if you will, in this situation. So I would probably be in favor of C5 blockade. I have a great deal of clinical experience with ravulizumab. We did not have the drug that was utilized in the Commodore trials, and by that I mean crovalimab. So I generally, and I'm not saying that if someone opted to go with crovalimab, it would be in error, because obviously it's a non-inferior drug to eculizumab, but for my clinical practice, I would probably go with the ravulizumab.
So, Alexander, the patient comes to you for a second opinion and says, I saw a doctor who recommended ravulizumab. What do you think? And again, put aside regulatory issues.
No, not the regulatory issues. And I mean, we just finished the German guidelines for PNH with the approval of those new drugs, and we put that was also in my previous answer. We were able to start with any kind of treatment we want to. So we have first line terminal complement inhibition, we have first line proximal complement inhibition, just to give you the freedom you want and you have to have, and it's based also on the clinical trials data. I mean, again, it should be individualized, and if this patient tells you, I want to get pregnant pretty soon and I'm not so good with taking pills, I mean, I would clearly go for a C5 inhibitor, probably ravulizumab, which is standard treatment, or crovalimab. If the patient says, I want to be independent, I'm traveling around, I'm fit, I have no problems taking oral treatment, iptacopan would be an option. And so on. So these are individual decisions you have to come up with. This patient is clearly a symptomatic patient. And the iron deficiency also makes it more severe in respect of the hemoglobin, and there's a clear treatment indication in this situation.
So actually, Gloria brought up a bunch of other specific issues as you talk about individualizing decision. Well, here's her individual issues. What about her, Gloria, as an individual?
I think we all actually hit a lot of these points. And I made this case, or I selected this case, because it's, a straightforward decision to treat. But I think right now with, in the last year, approval of multiple new complement inhibitors, every physician, including, individuals with a lot of expertise treating PNH patients has a different answer to, what you recommend. But the same answer is kind of counseling and discussion and eliciting patient preferences. So I think we touched on a lot of these. So the first was I brought up an issue of compliance. So you look through her outside records, and there are notes of several missed appointments and questions of alcohol use disorder. Given concerns for compliance, how would you change your recommendation? So I think Dr. Röth already commented perhaps on this. Perhaps you'd be less inclined to use an oral agent here where you don't know, if the patient's going to be compliant, and would consider something like ravulizumab where the patient is actually getting the medication, or here crovalimab because we are giving it. The second issue I think Dr. Röth also brought up, she travels frequently for work, sometimes internationally. She's very compliant, and she says, I want to minimize appointments. And then the third would be she's planning for pregnancy at some point in the next couple months to year. How would that change? And I think we all kind of addressed these already, but again, just the complexity of having these discussions with patients.
These points are so great. I really appreciate the way you wrote this up. I'm just come back to you, Jamie. Any thoughts about selection of a C5 inhibitor? There seems like a little bit of, I don't know, I'm not as clear on it as I thought I was going to be. Can you help clarify it?
Well, I think that, as Jamile pointed out earlier, our use of eculizumab is largely limited to pregnancy and to inpatient settings. I think we have, while we have non-inferiority data with ravulizumab compared to eculizumab, I think just given sort of the dosing frequency and other sort of exploratory endpoints that we have, most of us consider ravulizumab to be somewhat similar to eculizumab. I think in terms of crovalimab and ravulizumab, it comes down to a discussion with the patient. I think I would share with the patient, we have a large volume of experience and a number of years of experience with ravulizumab. This is the way it's administered. You're going to have to be either in the office or in your home every 8 weeks for a 1-hour IV infusion, versus for something like crovalimab, you're going to have to be, at least in the US, in the office every 4 weeks during maintenance phase for a subcutaneous injection. And, again, I think it really becomes a conversation with the patient. I think just a couple of points that I might bring out about this case. It was interesting, Gloria. I know that the PNH was kind of detected on the bone marrow aspirate. And I think in all the excellent discussion that we have had, I don't know if we've clearly stated that really the gold standard test for PNH is peripheral blood flow cytometry. So I thought that was sort of an interesting point of this case. The other thing that I want to mention is you give specific clone sizes in terms of the PNH RBCs and then I believe the PNH granulocytes, and we'll notice a big difference there. And, one thing that we believe about PNH is that the granulocyte clone size is probably the more accurate representation of true disease burden, because it's interesting, especially with these type 3 PNH cells that this patient has a high proportion of. These cells are often being so rapidly hemolyzed within the circulation that they're actually not surviving long enough for us to detect them on this assay. And also they could be, you mentioned this patient has been transfused. Those PNH RBCs could theoretically be diluted out. So I think those are a couple of other interesting important points about the case presentation. And, thank you for this excellent case. It's clearly generated a lot of discussion.
I'm curious, Gloria, what the patient actually was treated with and what her current situation is.
So the patient was actually treated with ravulizumab. And I believe she continues to be on ravulizumab and is doing well. This case might have been from a couple years back when there was not the same number of therapeutic options. But again, I think the consideration, this patient actually did come in saying that she was considering pregnancy. So that heavily biased the discussion, as well as I think that, some patients, to Jamile's point, was, some patients like the C5 inhibitors because there is, years and years of data with these agents, and other patients, seem to gravitate more towards newer agents, et cetera. So I think a lot of that can also go into the discussion as well. So I think just the longer term data with the C5 inhibitors plus the considerations around pregnancy, she was started on ravulizumab and is doing well.
Jamie has this 33-year-old African-American man. What happened with him?
So I initially met him when he arrived in my office to establish care. He had recently relocated to the New Jersey area. His history actually dates back quite a ways. He was diagnosed with aplastic anemia when he was 16 years old, treated initially with immunosuppressive therapy, was evaluated for an allogeneic stem cell transplant. But as is often the case with the African American community members, he didn't have a good donor. So he was not transplanted. After he received immunosuppression for his aplastic anemia, he did well for about a year, and then he started to develop dark urine. And at that time, he was diagnosed with PNH. This was actually in the pre-C5 era, believe it or not. And so at that time, he was really treated with support supportive management, the best supportive management that could be offered, which for him included prophylactic anticoagulation, quite a bit of transfusion support requiring 70 units of packed red blood cell transfusion over 3 years. Of course, with that came the issue of iron overload, and he was started on iron chelation therapy. So I think this just gives us like a little bit of a window into what this disease was like prior to the advent of C5 therapy. In any case, upon the commercial release of eculizumab, he was started on therapy with C5 inhibition. His hemolysis improved, his LDH levels reduced, and he ultimately became transfusion independent and eventually was able to even discontinue his iron chelation therapy. So upon presenting to my office to establish care, we confirmed his diagnosis of PNH with peripheral blood flow cytometry. He, again, has a very large clone, as we see here in the red blood cell line. It's 70%, granulocyte clone size is 80%, and monocyte clone size is 70%. So in my office, I continued him on eculizumab. When ravulizumab became commercially available with the every 8-week maintenance dosing, he was transitioned to ravulizumab. Of course, he much preferred that. And his hemoglobin stabilized, of course, on C5 inhibition with ravulizumab, but was still certainly not normal. Although he was transfusion independent, he had a hemoglobin running sort of in the 8 to 9 gram per deciliter range. His LDH was within normal limits, at times maybe slightly elevated, ranging from 200 to 270, but his reticulocyte count actually remained markedly elevated, was up to 12% at times. He continued to have an undetectable haptoglobin, and his direct Coombs testing was positive.
So how about if you come up with a bunch of questions for Alexander to answer about this case?
So I guess my first question would be, what do we think the etiology of this patient's ongoing anemia is? And, how might you address it?
I mean, given the fact that he has high reticulocyte count, it's clear in the positive Coombs test, which is also important to mention because a Coombs negative disease, PNH, turns Coombs positive on the treatment with C5Is, and that's the extravascular hemolysis. I think that's also something which helps you to actually diagnose extravascular hemolysis in part. Outside the setting of an experimental analysis of PNH red blood cells. And his significant extravascular hemolysis, I mean, hemoglobin is clearly not ideal, and I would really inform him about possible options to start on proximal complement inhibitors. I mean, pegcetacoplan, danicopan, in addition to the ongoing ravulizumab, which he's already used to, or iptacopan, completely oral treatment and independent of any other things, and only tablets which he has to take twice a day. And I think that's probably the choice he can make now.
So, Jamile, perhaps you can talk a little bit more about proximal complement inhibitors, which ones there are, in what situations they're used, upsides and downsides.
Yes. So thank you, Jamie, for presenting the case. That's actually a beautiful illustration of how PNH clones can grow in the setting of bone marrow failure. And just because someone responded to immunosuppressive therapy doesn't mean we should stop the monitoring piece. And also for a perfect depiction of what extravascular hemolysis means, and for checking a direct Coombs, because a lot of physicians actually realizing, as to Alexander's point, that this is a DAT negative disease, may not actually look for DAT positivity, but this is sort of the confirmation that we are dealing with residual anemia related to extravascular hemolysis. So we have several options. Going upstream in complement inhibition would be the way to go. Pegcetacoplan has been evaluated in the Pegasus trial, and actually any way you look at it, in terms of hemoglobin parameters, this patient would have fit in any of the potential 3 clinical trials that evaluated residual anemia due to EVH in patients who are treated with C5 blockers. So in the Pegasus trial with pegcetacoplan, it was any hemoglobin below 10.5, right, or transfusion dependency. In the iptacopan trials, anybody with hemoglobin below 10, and evidence of reticulocytosis. And in the danicopan add-on trial, it was any hemoglobin below 9.5. So any way you look at it, the patient could qualify. The responses for all complement inhibitors, of course, in danicopan's case, it was an add-on. It's sort of a proof of concept that if you block the complement upstream, and you abrogate extravascular hemolysis, you're likely to have improvement in hemoglobin. So you could automatically imagine that the hemoglobin in this case will improve if you either added or switched altogether to any of the complement blockers. And then I think here it would be so important to have a discussion with the patient as to the various therapeutic options that we have. In my practice, I have had patients who have chosen one over the other, not because of clinical trial data, but simply for logistical reasons. Some people preferred to switch altogether to a tablet. Some felt the comfort in knowing that they are on Ravio and now they can have one other medicine, as in danicopan, to improve their anemia. And some automatically said, I prefer to do this at home, and then went to pegcetacoplan. So I can't overemphasize the importance of having a conversation with the patient.
Just a follow-up to that, Jamile, what about proximal inhibition up front? So
I'm someone who likes to go with clinical trial data. I think there's ample evidence that the safety and efficacy of proximal complement inhibitors frontline, and we're talking here about iptacopan and pegcetacoplan. And in those instances, patients responded, and they responded beautifully, right? But in the iptacopan phase, it was a single arm. It wasn't compared. And there's no reason to believe that it wouldn't be just as effective as it was in treatment experienced. But I think I need to explain this to the patient, that these are newer agents that we have less knowledge about how they compare frontline to standard of care, at least with C5 blockade. And in the same manner with pegcetacoplan, when you think about frontline therapy, it's clearly that there's efficacy there, but it's not compared to, again, C5 blockers or any other PNH therapy. So if we are limiting our discussion to results of clinical trials, I will frame it as such. And if the patient is willing to utilize frontline treatment with proximal complement inhibitor, I will certainly facilitate that, because I believe that we have sufficient data, but not in comparisons to standard of care. And that's what I'm trying to emphasize.
So, Jamie, you've gotten some feedback on this case. Any other questions you have for the faculty about the case? Any follow-up on the patient?
I would just add that, again, due to the timing of therapeutic availabilities, the patient was started on pegcetacoplan, had a very nice hemoglobin response with an improvement in hemoglobin of 3 grams per deciliter or slightly more. Interestingly, when I looked at this patient's platelet trend, we saw that although the patient's platelets had never been elevated, I actually did see a downward trend in his platelet count, not to the point where the platelets became low, but it just makes me wonder with the EVH that was going on, if it was generating some type of inflammation that was driving his thrombocytosis or increasing the platelet count as possibly an acute phase reactant. So just an interesting observation about this patient. I mean, obviously, the discussion would be a lot different with, now 2 other options in addition to pegcetacoplan, which he could potentially have used to address his clinically significant EVH.
Jamile, any other thoughts on this, and any thoughts specifically on iptacopan and its future?
So I will comment on the thrombocytopenia that Jamie talked about. And I wonder, because your patient had DAT positive test, you wonder if the antiplatelet antibodies may actually be there, because as you know, platelets also have the same deficit as red cells have. So just a thought. But relative to iptacopan, I have to say that the clinical trial data in terms of hemoglobin improvement and control of hemolysis, both intra and extravascular, are impressive. I mean, unprecedented number of patients who have hemoglobin above 12 grams. Normalization of hemoglobin is remarkable. And then also in people who have been treatment experienced, again, very remarkable. So I think that we are in a very good time at the moment to choose certain therapies for our patients that will have tremendous outcome. And I think the question right now is, what is the quality of life of those patients, and what are some of the long-term consequences of the treatments that they are receiving? It's going to be putting back compliance frontline. Patients need to understand that they have to be on those therapies, whereby with IV treatments, I know I've given it to the patient, but here I'm relying on the patient to take the treatments. And fortunately, the compliance rate in the clinical trials have been really high, and upwards of 90%. So again, we have not been in a situation before where we had so many different therapeutic options, but now we do, and it's a good thing.
Jamie, thank you for this case. I think it's very interesting, but I think it also brings up some, if we changed it slightly, like this patient very clear, well, I'll say as a mechanistic consequence of C5 and extravascular hemolysis is a mechanistic consequence of C5 inhibitors. And the vast majority of patients on C5 inhibitors have some extravascular hemolysis. Now, whether it's clinically significant, leading to, more severe anemia, transfusion requirements varies, and maybe we estimate that percentage of patients to be somewhere closer to 25 or 30%, which is, I believe others have said. I think a debate currently in the PNH field that is, let's say this patient, instead of having a hemoglobin of 8 to 9, has a hemoglobin, let's say, around 11 as a median, but has these markers where clearly there's still extravascular hemolysis that's ongoing. And let's say he says, I feel tired sometimes, but, he goes to the gym 2 or 3 times a week. It's not significantly interfering with his quality of life in a way we can tell, but maybe mild symptoms of fatigue. But, there is data on the proximal complement inhibitors that we might have more of a hemoglobin normalization. So maybe his hemoglobin would be 13 on the proximal complement inhibitors or 12. And I was just wondering from the group, kind of what's your thinking on patients who fall into that category where they have kind of more mild anemia, markers of extravascular hemolysis, and this idea of hemoglobin normalization?
Yeah, I think that's a good question. And I think it really boils down to how motivated is your patient to switch or add on treatment to what they are experiencing. A lot of times they might want to just have a discussion. But in my clinical practice, I find that that I think motivation is key in this situation. Fewer patients are likely to make any treatment changes if their hemoglobins are upwards of 10.5 or 11. But is it to say that maybe they were destined for hemoglobin of 13 and 14? I think that's a different endpoint, actually, that wasn't necessarily targeted by the clinical trials, because the lowest hemoglobin was 10.5 or transfusion dependency. But this might become more of a question to us as time goes on. Why should I be living with a hemoglobin of 11? And I think that, again, it's back to having a discussion with the patient on what does clinically significant extravascular hemolysis means to somebody. So I don't know that I have a solid answer for you, but again, back to discussion with the patient.
So we're going to go with another case from Gloria.
So this is a 50-year-old woman who has a remote history of aplastic anemia, who was treated years ago with immunosuppressive therapy. Her counts have been monitored, and she has ongoing, very moderate thrombocytopenia without any bleeding symptoms. Her platelet count is about 70,000. And over time, she develops a PNH clone. Her LDH is normal at 200, and her hemoglobin is in the 11s, and her reticulocyte count is not elevated. On peripheral blood flow cytometry, her PNH red cell clone is quite small, just less than 1%. But her white blood cell clone is much larger. So 75% of her granulocytes, and about 72% of her monocytes are GPI deficient. And so you continue to monitor her over time. Her blood counts, LDH and PNH clone remain generally stable. And she's asymptomatic. On routine follow-up, you get a CBC and you notice her platelet count now has dropped to about 42,000, but her other blood counts are unchanged. Her CMP is within normal limits. You get a D-dimer, which is now elevated to 5 and was previously normal. Her other coags, her prothrombin time, and her PTT are not elevated. This prompts you, despite symptoms, to get abdominal imaging that shows a non-occlusive thrombus involving the portal vein and splenic vein. She has splenomegaly and some perisplenic varices, suggesting some degree of chronicity. She has started on ravulizumab because of this acute clot. And I brought up this case just because I think this is a less common presentation of PNH, where we see this quote unquote ahemolytic PNH with a large granulocyte clone, but these patients are still at risk for thrombosis. And there's actually growing literature to suggest that these patients who either have a large type 2 PNH clone or this very large disparity between the PNH red and white blood cell clone are at some of the higher risks for thrombosis, especially at atypical sites like in the splanchnic circulation. And I wonder how others are monitoring these patients.
Alexander?
Yeah, no, it's I brought it up, and I think it's an important issue because they are not so simple to identify because they have a normal LDH level usually, and just come up with thromboembolic events. In our situation, the patient was coming also from plastic anemia, and developed this difference between red blood cells and granulocyte clone size, and developed stroke. So he got his first stroke, and he was started on prophylaxis for his stroke with an aspirin and a statin. And then he had a second event actually, and with this we started him on complement inhibition. And ever since his D-dimers went down, and since then he had no event. So that's kind of striking, and so it could not only be venous thrombosis, but also arterial events happening in the situation of a PNH clone within a hemolytic PNH.
May I ask a question to the presenter?
Sure.
So then, in the cases of Gloria as well as Alexander's of ahemolytic PNH, what happens after you treated the patient with ravulizumab? Did the red cell clone size increase?
No, not in her case. It didn't, or if it did, it was still very, very low. And we have serially followed these patients with D-dimers and watched them, because I think it was 10 plus years where she was otherwise asymptomatic and monitored. But I think
And I ask because this kind of challenges the common knowledge that if you have a PNH clone that's hemolyzing, you have high LDH, you have high propensity for thrombosis, but in both cases, you have almost non-existent red cell clones. So if the assumption is that it was like completely hemolyzing, you're not detecting it, or you would imagine then the ravulizumab would make the red cell clone much higher because you're salvaging those cells, but that's not the case. But I would like to emphasize that within PNH, which is very rare, that those cases are even much rarer. So I think it's important to kind of recognize that this is a defined different form of PNH, if you will, in the sense that it doesn't have straight hemolytic parameters, etc., but it's very uncommon.
It's the chameleon of the zebra. I think that's how you can see that. And I just want to say, same here, we didn't see an increase of the PNH red blood cells, but we saw a continuous control of the D-dimers, which went down. And so that was kind of a parameter we were following.
That was the same thing in our case as well.
All right, let's see if we can squeeze in one more case. Jamie, you have a 28-year-old woman I like this title, interestingly, wants to discuss alternative treatment options. What happened with her?
So, this is a 28-year-old female who was actually in her normal state of health until the spring of 2017. She actually underwent routine evaluation prior to enrolling in pharmacy school. She was found to be anemic and have some thrombocytopenia. So she was referred to another hematologist, oncologist. She, at that time, had some symptoms that were consistent with pica. She was found to be both iron deficient and B12 deficient. She was supplemented, but still remained mildly pancytopenic. And unfortunately, at that time, she was actually lost to follow-up due to insurance issues. She again resurfaced about 2 years later, and this time her counts were acutely lower. She had some leukopenia with a white count of 1.72. Her hemoglobin was 8.9, and platelets were 51,000. She did have evidence of active hemolysis, and she had a markedly positive PNH clone. Her monocyte clone size was 66%. She underwent a bone marrow biopsy, which was 20% cellular, no evidence of blasts and diploid cytogenetics. And again, she had evidence of persistent hemolysis. Her LDH was greater than 2,000. She had an undetectable haptoglobin. So there was certainly felt to be a component of bone marrow failure for which she was started on cyclosporin given non-severe aplastic anemia. And she was also at that time, given the availability of therapy, started on eculizumab to address her PNH clone with evidence of active hemolysis, thereby putting her at risk for thrombosis. She was later transitioned to ravulizumab when it became available, and she was able eventually to have a response of her other cytopenias and taper off of her cyclosporin. So at this time, her CBC shows mild leukopenia with a white count of 2.65. Hemoglobin is 11.1, and platelets are normal at 215,000. She has a mildly elevated reticulocyte count of 3.89%, with the upper limit of normal being 2.2%. She has normal LDH, and haptoglobin is also within normal limits with a value of 90. She mentions that she travels frequently for work and also for personal reasons. And she had actually been planning a trip last Thanksgiving, but she was due for her ravulizumab dose the day after Thanksgiving, and she has asked me about other treatment options.
So, Jamile, any thoughts?
So the choice is here for logistics because the hemoglobin is definitely reasonable at 11.1. So what might be a possible scenario here is that maybe she could, I don't know how she would feel about having iptacopan, for example, because that minimizes the back and forth to infusion, albeit every 8 weeks, and gives her more freedom. But on the other hand, this is also a patient who was lost to follow-up and travels, and would there be more concerns about her forgetting to take her tablets? So again, this isn't necessarily in an attempt to control clinically active EVH or even ongoing breakthrough hemolysis because of not insufficient complement inhibition. This is just logistical treatment switch. So it's basically a conversation. And I had a very similar patient, happened to be young and wanted to be infusion free. So we ended up resorting to iptacopan.
Any other questions about this case, Jamie? Any other thoughts about this case and any follow-up?
So the patient did indeed switch to iptacopan. She has been tolerating it very well. Interestingly, although her hemoglobin was sort of lower limit of normal to begin with, she did experience some improvement in her hemoglobin to a value around 13, and she has been compliant and happy on iptacopan.
Did you check her on her fatigue?
So I did not. I mean, that was really not necessarily the reason that she was endorsing for wanting to change therapies. But, you know, I think actually to the point of Gloria's earlier question, it is really important that we include facet fatigue. as an endpoint in these clinical trials, which it has been included as in the clinical trials, right, of looking at pegcetacoplan and looking at iptacopan, because hemoglobin in the end is just a number. And what is really important is the way that the patient feels. And I think even beyond that, there are efforts to kind of standardize not just facet fatigue, but actually a PNH specific quality of life tool that applies specifically to this disease state. So I think that this is some of what we look forward to in the coming years to further the treatment of these PNH patients. So I think that's an excellent point regarding fatigue and potentially using these fatigue scores as endpoints in clinical trials.
I have a short question, I promise.
No problem.
So in these patients who are now being transitioned to self-administered therapies, like oral options, there isn't a defined frequency of laboratory monitoring. And I was just wondering everyone's practice, because I think that could be helpful.
Alexander?
Yeah, that's a really important question, and depends also on the history of the patient. So now I'm following patients for over decades, and we know each other really, really good, and I can rely on them that they know what they are doing, and they will come in if they have problems or issues. For patients newly diagnosed with PNH, they have to go all through that and have to learn to understand their disease. And there I would really see them on a more regular basis, every 2 to 4 weeks, at least in the beginning, and then see how it's going and if they will are compliant with the medication, and later on extend the intervals. And I think that must be adjusted to the patient. And I really you really need this teaching of the patients about the disease, possible complications, especially issues with iptacopan, with this accumulation of this huge PNH clone, and the risk for breakthrough hemolysis and so on, and what the patient has to do. So that's my point here.
Any other questions or points or things that maybe we didn't get into that we maybe could have gotten into? Anything anybody would like to add?
There's one practical thing what I would recommend. We talked about vaccinations and we talked about the risk for severe infections. What we do in our patient group, and this goes back to the initial trials, is we have this standby antibiotic or pill in the pocket, how you might call it. And they're advised to take if they have signs of severe infections like fever, etc., and they are supposed to take. And what we now do is a combination of penicillin, amoxicillin, and clavulanic acid. And because we have this bigger spectrum of infections, especially with the proximal complement inhibitors, and they're supposed to take one and immediately see a doctor just to prevent any further severe complications. I think that's a good thing to do and to advise the patient in this respect.
This concludes our program. Special thanks to our faculty, and thank you for listening. This is Dr. Neil Love for Practical Perspectives in the Current Management of Patients with Paroxysmal Nocturnal Hemoglobinuria.